Mike Sharma and I talking to you live from the ISC, the International Stroke Conference. Mike, you just stepped off the podium presenting the results of the Oceanic Stroke Trial. Talk to us a little bit about why you did this study.
Thanks so much, Mike, and thanks for the opportunity. For about 50 years, for long-term stroke prevention, really the only antithrombotic we've had is aspirin, sometimes clopidogrel, but monotherapy. We've been trying to improve on that for decades. We failed either because the agents were ineffective or they caused unacceptable bleeding. The only thing that came along that helped us was Compass. Low dose rivaroxaban with aspirin, which reduced stroke in a select group of patients. And that gave us the idea for this dual pathway approach. But we started it because there was a real clinical need for something better.
And, talk to us a little bit about why factor 11. What is it about it? What is it about the demographics? I mean, I know that it reduces VTE in Mendelian randomization models, but it also reduces stroke. Those people who have, genetically inherited low levels have lower stroke, right?
Yeah, absolutely. So, your chance of being genetically factor 11 deficient is about 1 in 1 million. And if you are, then you have a substantially reduced risk of stroke as well as DVT. And spontaneous bleeding in these people tends to be pretty rare. And intracerebral bleeding, which is a big concern to us in the stroke field, isn't increased with factor 11 deficiency. So this combination of a reduction in ischemic events and safety that really makes it an attractive target.
So Nature did the randomized trial. Now you did the real human trial. Like, so talk to us about the design of the study.
So Oceanic Stroke is a big international placebo-controlled event-driven randomized trial. So we did this in 37 countries, 702 sites. And basically what we did was we recruited people who had either ischemic stroke or high-risk TIA within 72 hours of the event. They're randomized 1-to-1 to either asundexian, 50 milligrams once a day, or matching placebo. Now, importantly, all of the participants had to have a plan for antiplatelet therapy, either dual antiplatelet therapy, aspirin plus a P2Y12 inhibitor, or single antiplatelet therapy. And Mike, as you know, in our field, dual antiplatelet therapy is usually indicated for a limited period of time. Varies a bit depending on the patient, but could be up to 90 days or as short as 21 days.
Mm-hmm. So what did you find?
So it was a very satisfying result. So asundexian was associated with a 26% reduction in the hazard of stroke. So the hazard ratio is 0.74. The absolute risk reduction at 1 year was 1.9, which translates to a number needed to treat of 53, which is very attractive for a preventive treatment. Now, as you go on, the number needed to treat drops because most gratifyingly, we saw this effect size with no increase in ISTH major bleeding, and all of the other types of bleeding were similar in placebo and asundexian arms. So that includes bleeding in the brain. It includes clinically relevant non-major bleeding, as well as minor bleeding. Now, minor bleeding, I think you and I in our trials haven't paid much attention to, but listening to patients, to stroke survivors, it's a huge issue for them. It's visible, it causes them fear. Sometimes they stop taking medication. So very nicely, we saw this impressive reduction in the occurrence of stroke without a price to pay in terms of bleeding.
Wow, after all these years, we finally got a free lunch.
Yes.
Benefit without a safety problem, a free lunch without catch up, as I like to say. So as you go out longer, you start off with the number needed to treat of 53. Where do you end up at the end of the study? How many people would you need to treat to prevent a stroke by the end of the study?
By the end of the study, it's down around 45, and those curves are still separating. So, as time goes on, it becomes even more attractive to treat people with this agent.
And when you say stroke, Is that ischemic stroke or ischemic stroke and hemorrhagic stroke together?
Yeah, thanks for letting me clarify. It's ischemic stroke, which was our primary endpoint. This is something we wrestle with in every trial, whether to include both types of stroke. But if you do that, you're actually double counting because it's also a safety outcome. So ischemic stroke was our endpoint.
Yeah. Any subgroups that derived greater benefit than others?
So I'm really happy to say that we saw consistent effect across subgroups. So this includes people who were older, men and women, their risk factors, including coronary disease in the past, the severity of the stroke. So very often, we're concerned that more severe strokes might not benefit, but they did. In this, everything was really very consistent. And one thing of importance to stroke neurologists is we saw consistent benefit across the stroke subtypes. So there was concern that we might see it only in atherosclerotic disease, but we saw it there. We also saw it in small vessel disease, which I would not have predicted before.
No, I would
Yeah,
not have. I mean, anticoagulants have not succeeded
they have
in
not.
that subgroup.
And yet here it
Uh,
was. Effect size
wow,
about the same. Yeah.
the
And
same.
yeah. Likewise with cryptogenic stroke, this ESUS group, where we don't know where the embolus originates, very consistent benefit in all these subgroups. So what this means in practice is, once it's available to us, once it's approved, is that we won't have to think very hard. There won't be a lot of work to subclassify the patient to see whether or not they're a candidate. Uh,
Well, that blows me away, Mike, because I thought, the lacunar strokes, the small vessels wouldn't benefit. Just all good news all the way around. Will this change practice?
I expect it to fundamentally change practice, and it changes our paradigm of thinking about things like small vessel disease. In SPS3, we saw no benefit from dual antiplatelets compared to aspirin, some hazard, but yet clearly there are thrombotic events involved in that. And just because of how easy it is to implement this in someone's practice, I expect it'll easily change practice. And there isn't a hazard for bleeding. So unlike dual antiplatelets, where we have to pay attention to stroke severity, which is a marker of the risk of bleeding, here, up to an NIHSS score of 15, we did not see any hazard. So more severe strokes as well. I think this will fundamentally change how we approach this problem.
Now, no excess major bleeding, no excess ICH, but what about clinically relevant non-major bleeds?
So I'm happy to say that wasn't increased either. And we didn't see an increase in the combination of ISTH major and clinically relevant non-major bleeding. It
Wow,
was very similar to placebo.
wow, that totally blows me away. I got to say, unbelievable. So really, truly, no increase in bleeding and all upside. Just
Yeah,
amazing,
it
amazing.
is.
Well, it does, you know, kind of show that the Mendelian randomization data was right.
Yes.
Lower risk of stroke without bleeding.
This was unexpected, but really quite lovely to see all of this consistency across subgroups without the hazard.
Yeah.
And if you compare it to a lot of trials, you've done a number of these trials with antithrombotics, always a little bit of a price to pay in terms of bleeding. And here we don't have it. Just to repeat your words earlier, closest to a free lunch you're ever going to get.
Well, the world is lucky. I'll say that. And we're lucky to have you, Mike, and your leadership in this trial. Congratulations. I do think this changes practice. I think it's great news for patients. That kind of benefit without an excess risk of bleeding, never been seen before. Just amazing. Congratulations, Mike, to you and all of your investigators.
Thanks so much, Mike. It's a pleasure talking to you.